Okay, good morning, everyone. After a fantastic conference, now we are back to our routine, and this is our routine that we start our week with the fantastic classes. So this time this turn is from of Tata Memorial Hospital. I request Dr. Joyita, who is I know we don't need any introduction uh, for anyone. I think everyone knows Dr. Joyita very well. She's heading the Department of Palliative Medicine at Tata Memorial Hospital. So I request Joyita to introduce speaker as well as moderator. Joyita, please go ahead.
Good morning, Sushma ma'am, and good morning, everyone. It is our pleasure to introduce our moderator and speaker for today. The topic is physiology of the dying patient and the symptoms of actively dying, management of the actively dying patient. And to present this is Dr. Dhanashri Kudal, who is our third year resident in Department of Palliative Medicine at DMH. Dhanashri has done her ECHO Pediatric Palliative Care Certificate Program. She also has done a poster presentation at the last IAPC 2022, and her areas of interest are neuropalliative care and palliative medicine and oncology in the emergency settings, as well as she is interested in renal supportive care. Our moderator is Dr. Prajakta Bhagat. She has passed her MD Palliative Medicine in 2021, and she is currently senior resident in Department of Palliative Medicine at DMH. Her interests are pediatric palliative care, as well as her interest is in palliative care in gynecological malignancies and palliative medicine for respiratory disorders. And apart from their interest and dedication and work in palliative medicine, Dhanashri has an interest in sports, and she recently was part of the team and won in our athletic meet. And Prajakta is a very accomplished artist, and she has beautiful drawings, and she teaches the rest of us how to draw. So over to you, Dr. Dhanashri, and for moderation, Dr. Prajakta. Thank you.
Good morning, everyone. Thank you for the warm introduction. Good morning. Topic for today's presentation is physiology of actively dying and management of actively dying patient. Agenda that will be covered today is definition of actively dying and physiology of actively dying, good death, quality of death and dying, symptom management at end of life, palliative sedations, end of life discussions with patients and families, guidelines and policies of end of life care, international as well as Indian guidelines, 10/40 model for best care of dying, and Liverpool care pathway. Definition of actively dying. Although the term actively dying is commonly used in clinical practice and research articles, there is no universally accepted definition. The systematic review of literature textbooks conducted by Hugh et al. In 2014 identified that actively dying can be described as the final hours or days of life. This definition corresponds to the occurrence of specific and irreversibly physiological changes that signal an irreversible decline with a median onset of approximately 3 days. Physiology of dying includes changes that occurs in the last weeks or days of life. These can help in understanding the process so as to provide better care for the patients and families. Characteristic decline in physical function, nutritional status, respiratory function, and cognition as a result of progressive cancer and acute symptomatic complications. These changes correspond to worsening performance status, anorexia, cachexia, breathlessness, delirium, which are prognostic factors in patients with advanced illness. Here is the conceptual framework of time process. in which physiological changes which are seen months before the death include decreased performance status, weight loss, organ dysfunction, acute complications. Cognitive changes are patient is usually normal but is at risk of delirium, and there is fluctuating and gradual decline in the condition of patient, which is potentially reversible. Physiologic changes seen weeks before the death, that is in the deterioration phase, includes accelerated decline in performance status, anorexia cachexia syndrome, dyspnea at rest, organ failure, acute complications. Here the delirium is likely and a steep decline in function, which is potentially reversible but less responsive to interventions. Days and hours before death, we see late signs of impending death, abrupt vital sign changes, cardiovascular collapse, and respiratory arrest. Here, the patient suffers from severe delirium, which is unresponsive and irreversible process. Next is change in vital signs in the last 14 days of life. Blood pressure and oxygen saturation often decreases in the last days and hours of life. Clinical signs of impending death includes dysphagia through liquids, decreased level of consciousness, palliative performance scale reduces to less than 20%, peripheral cyanosis, Stokes breathing, urine output is decreased over last 12 hours, that is less than 100 ml, apnea periods of breathing, respiration with mandibular movement, death rattle, and pulselessness of radial artery. Frequency of 6 late signs of impending death is decreased response of visual stimuli seen in few days of life, decreased response to verbal stimuli, drooping of nasolabial fold, hyperextension of neck, and inability to close the eyelids and grunting of vocal cords, which is approximately 40 to 20% cases. 3 early and 7 late signs of impending death are usually seen. Early signs of impending death have higher frequency but lower specificity for impending death in 3 days. In contrast to late signs of impending death have lower frequency and very high specificity for impending death in 3 days. The signs include decreased level of consciousness, decreased palliative performance scale, and dysphagia to liquids, decreased urine output, peripheral cyanosis, and death rattle. Then definition of signs of impending death. Neurological signs include non-reactive pupil, that is lack of pupillary reflex to light stimuli, Stokes breathing, that is alternating period of apnea and hyperapnea with crescendo and decrescendo pattern, decreased response to verbal stimuli, that is unable to follow verbal commands, no verbal communication, decreased response to visual stimuli, that is no eye tracking movement, apnea periods, that is prolonged pause of more than 20 seconds between each breath. Neuromuscular, it includes inability to close eyelids, that is eyes stays open and no blinking is observed, not able to close when asked, grunting of vocal cords, that is sound produced predominantly on expiration related to vibrations of vocal cords. Respiration with mandibular movements include depression of jaw with inspiration. Death rattle includes gurgling sound produced on inspiration and or expiration related to airway secretions. There is drooping of nasolabial fold, decrease in prominence and visibility of nasolabial fold. Hyperextension of neck includes neck extension when patient in supine position. Cardiovascular signs includes pulselessness of radial artery, that is inability to palpate radial pulse on both or one side. Urine output over less than 12 hours is 100 ml over a period of 12 hours. Upper GI bleed signs like hematemesis and melena, and peripheral cyanosis, that is discoloration of extremities. Next term, we are going to see good death, which was given by Smith. It includes principles of good death includes to know when death is coming and to understand what can be expected. It is something to be able to retain control of what happens, to be afforded with dignity and privacy, to have control over pain relief and other symptom control, to have choice and control over where death occurs, and to have access to information and expertise of whatever kind is necessary. Here in good death, we have access to any spiritual or emotional support required. is to have access to hospice care in any location, control over who is present and who shares the end, and to be able to have issued advance directives, ensuring that one's wishes are respected, to have time to say goodbye and control the timing, to be able to leave when it is time to go and not to have lifelong pointlessly. Components of good death is pain and symptom management, clear decision making with reducing the fear of pain, and inadequate symptom management through communication and clear decision making with physicians and empowering the families in decision making. Then preparation for death, incomplete knowledge, and importance of spirituality and meaningfulness at the end of life with dealing the faith issues, life review, resolving conflicts, and spending time with family and friends and saying goodbye. Contributing to others in acknowledging and making provisions for terminally ill patient to contribute for the well-being of others. Affirmation of the whole person. Affirmation in the sense the patient has a unique and whole personality with not understanding the patients from disease perspective with understanding in the context of their lives, values, and preferences. Then management of an actively dying patient. 6 steps of end-of-life care process includes identifying, assessing, plan, provide, and reassess with reflect. In detail, we should identify when and in whom to initiate the symptom management of end-of-life care. Then assessment of physical symptoms, distress, non-physical issues, and communication needs. To plan for site of care, review existing care protocol, medication chart, stop unnecessary medications and investigations or interventions, anticipatory prescribing and writing, communication, consensus, and consent is taken to provide essential medications for end-of-life symptom control, dedicated space and round-the-clock staff, special care needs of the patient and the family, and after death care and bereavement support. Reassess is to ensure adequate control of symptoms through ongoing assessment and documentation in any variance and initiate prompt action. And reflect is to review the care process and identify if there are any gaps. The symptom management, symptoms in actively dying patient must be assessed at least once a day. Symptoms must be anticipated and anticipatory prescription should be written up. Access and availability of essential medications for symptom control should be ensured. Medications and doses prescribed for symptom control must be based on careful evaluation of patient symptoms and problems. Dosage should be proportionate to the patient's symptoms and response to treatment should be frequently reassessed. Simplification of the medications should be done. We can reduce or stop the long-term prophylactic medications like statins, antihypertensives, OHs, and warfarin. PRN and SOS orders should be written up to cover intermittent symptoms and to cover breakthrough symptoms and events. Liberal use of PRN medications and rapid readjustment of dosage of background medication should be done. Route of delivery, drug delivery should be most reliable, least invasive, and convenient. Empower and educate the family and the caregivers to participate in symptom management and care process. Consider palliative sedation even when symptoms are refractory to adequate and aggressive palliative care. The next first symptom is pain. Continue ongoing analgesics and opioids. Change the route of administration. We can convert oral medications to parenteral or subcutaneous or sublingual or transdermal. Morphine, subcut or IV injection or transdermal fentanyl at home as intermittent or continuous infusion can also be preferred in hospital and ICUs. Increase in background PRN as well as liberally used doses. Then neuropathic pain. For neuropathic pain, we can use lignocaine, ketamine, subcut or IV as per the dose preferable. The next symptom is dyspnea. Up to 70% of patients experience dyspnea in last 6 weeks of life. Multifactorial and treated the correctable causes of dyspnea. Like in case of pleural effusion, we can consider for thoracocentesis. Non-pharmacological methods include fan, positioning, relaxation, and breathing techniques. Use of bronchodilators if indicated, and oxygen therapy useful only in those with hypoxia. In pharmacological management of dyspnea, we can consider opioids like morphine, subcut or IV in 1 to 2.5 milligram Q4 hourly for breathlessness in the opioid name with 24-hour total doses. And associated with anxiety, lorazepam can be considered 0.25 to 1 milligram thrice daily. For refractory breathlessness with severe distress, we can consider midazolam from 1 to 5 milligram Q4 hourly IV. Muscle relaxants may be used if patient is on ventilator, and non-invasive ventilation may be considered. For agitation and delirium, 88% of the patients have been found to have agitation and delirium in end of life. Hypoactive and hyperactive delirium are two types. Refractory delirium itself is poor prognostic factor and precedes terminal phase. Rule out the correctable causes before diagnosis as terminal delirium, as it impedes the communication, affects symptom reporting ability to make decisions or participate in decision making. Family distress and burden of decision making is increased with delirium, with misinterpretation of agitation as pain. Challenges, professional caregiving and difficult assessment is seen, and management goes difficult. In non-pharmacological management, we should consider frequent orientation, dim lighting, natural daylight. Sensory aids like glasses and hearing aids should be used. Familiar objects should be kept nearby. Consistent caregivers, relaxation techniques, daily routine should be followed with limited sensory overstimulation. And pharmacological management, antipsychotics used are haloperidol 1.5 to 5 milligram TDS with maximum of 50 milligram per day IV or subcut. Also, we can consider olanzapine, that is per oral or sublingual IV 2.5 milligram BD, or chlorpromazine. In benzodiazepines, we can consider midazolam 2.5 to 5 milligram Q4 hourly, IV up to 80 milligram per day, and clonazepam 0.5 to 1 milligram TDS sublingual or subcut. Another symptom is nausea and vomiting. We should review the current medications and discontinue any non-essential precipitating drug which can cause nausea and vomiting. Treat the reversible causes, example, hypercalcemia. Anticipate and prescribe a regular oral antiemetic. If a patient is actively vomiting, consider parenteral route. First line management for nausea and vomiting is metoclopramide, subcut or IV, TDS, QID via syringe driver over 24 hours. And we can also use primarily central haloperidol, which can be given subcut or IV route, 0.5 to 1.5 milligram BD or TDS. To maximum over 24 hours, we can consider 15 milligram. Second line also includes levomipramazine and cyclizine. In gastrointestinal obstructions with colicky pain, we can consider injection hyoscine butyl bromide, that is Buscopan IV or subcut from 20 to 40 milligram QID up to 240 milligram per day. With refractory vomiting, we can consider octreotide IV for from 100 to 300 mics, TDS up to 1200 milligram per 24 hour. And next comes terminal secretions or death rattle. 44% of time patient experiences this death rattle. Type 1, that is 2 death rattle. Here the mechanism is uncertain, maybe due to pooling of saliva or secretions in the upper airways and reduced swallowing reflexes, dysphagia and inability to expectorate. In type 2, that is pseudo death rattle, due to pooling of secretions, death rattle usually occurs over days and not responds to any anti-muscarinic or anticholinergic medications. This pseudo death rattle is seen example in bronchoria from primary lung tumor infection, dysphagia, bleeding, airway obstruction, pulmonary edema, or tracheoesophageal fistula. There is no significant association between hydration status and development of death rattle. In RCT conducted by Wilgers in 2009, anticholinergic drugs in 333 patients showed beneficial effects in almost 76% of the patients. Anticholinergic which are used when patient is unconscious is hyoscine butyl bromide, subcut 0.4 milligram Q2 to Q4 hourly with maximum dose of 2.4 milligram Q24 hourly. And when conscious, glycopyrrolate can be used from 0.2 to 0.4 milligram Q2 or 4 hourly. There is ongoing trial, that is silence RCT, on effectiveness of prophylactic subcutaneous scopolamine butyl bromide on death rattle in patients at end of life. We should also reassure the family that terminal secretions are rarely distressing to the patients, although may be distressing to family. Then nursing interventions seen to be done in dying patients include skin care, that is positioning, comfort beds, pressure point care. Then in mouth care includes hydration with unflavored sponge tippets fab every 2 to 4 hourly. Avoid commercial mouthwashes, lemon glycerin and artificial saliva. Eye care, we can use methylcellulose eye drops. Prefer nasal prongs if on O2. Avoid restraints, avoid excessive monitoring. Permit family members to stay. Parenteral hydration in end-of-life patients. Hydration did not improve quality of life or survival of patients as per the evidence. In Cochrane's systematic review regarding medical hydration of end-of-life does not show any significant benefit of hydration. These are some evidences which provide the same, that hydration did not prolong survival nor significantly improve dehydration symptoms of terminally ill cancer patients, but it may influence the quality of dying. Communication with patients and their families on the effect of artificial hydration may help them better to prepare for end-of-life experience. Then bowel and bladder care. Continuous care is an essential medical nursing aspect of care in end of life. Poorly managed bladder or bowels lead to urinary retention, incontinence, fecal impaction, and delirium in elderly. During end of life care, the final phase of dying, the sphincters could relax and lead to incontinence. Alternatively, retention can occur due to the drugs used for symptom control. Prompt recognition, pads, indwelling catheters may be used. Proactive measures needs to be taken to prevent constipation, fecal impaction in end-of-life care. Rectal interventions are often required in patients with altered sensorium and unable to take orally. Now, terminal emergencies includes acute stridor, which requires immediate sedation with IV midazolam, 5 to 20 milligram, the dose being dependent on whether the patient recently had received the dose and in what amount. Then in massive hemorrhage, it is a catastrophic event. If the event is anticipated, use dark towels and blood loss. This makes blood loss less obvious. Then midazolam should be available and it can be given from 5 to 20 milligrams to decrease the distress and anxiety for immediate sedation. Then seizures, acute and maintenance doses includes midazolam, subcutar IV or buccal, 2.5 to 10 milligrams stat and continuous dose of 10 to 20 milligrams. Maintenance for seizure prevention. Also, we can use clonazepam sublingual drops or a subcutaneous injection of 0.5 to 1 milligram stat. And then we can continue with 1 to 2 milligram for seizure prevention. Myoclonus is another symptom that is distressing to the family. Patients are often so ill or unconscious that they are unaware. It may be caused by dopamine antagonists, neuroleptics, high-dose opioids, or withdrawal of such drugs such as benzodiazepine, barbiturates, anticonvulsants, and alcohol. Treatment should include reviewing of all the medication and dosages, sedation with midazolam until the patient is restful, which includes 1 to 10 milligram every hourly to maximum 20 to 30 milligram per day, which can be given by intermittent or IV subcutaneous route. Alternatives include rectal diazepam and clonazepam. Next topic is palliative sedation. Palliative sedation is a spectrum of interventions where sedatives and opioids are used to relieve physical pain and distress of dying patient and end of life. For 5% terminally ill patients whose pain cannot be controlled by opioids, we can use palliative sedation. It is indicated at the end of life to treat intractable, intolerable symptoms such as extreme pain, dyspnea, nausea, and vomiting. It does not hasten the death. Conditions used include administered medication, offers legitimate patient's benefit. The intention is not to kill, and death is imminent. That is days or hours, not weeks or months. Dosages, proper doses that is sufficient to relieve pain and suffering. No maximum doses are used. Complication is The most challenging complication is crossing the line between providing pain relief and causing death. The intent of palliative sedation is relief of intractable distress, whereas the intent of euthanasia is to end life. It is the physician's responsibility towards hopelessly ill patients. Clinical significance is that most of these patients have significant opioid tolerance, so it would be misconstrued. Physicians are allowed to use opioid therapy at the end of life to prescribe a dosage deemed medically necessary. Medications used in the sedation that is administered without intending to cause a death, utilizing a non-opioid drug to control intolerable symptoms that are refractory in patients with advanced or incurable disease whose death is imminent. Intolerable symptoms are those that are intolerable as defined by the patient. In non-communicative patients, symptoms may be assessed by the healthcare providers with input from family and caregivers. Refractory symptoms are those symptoms that remain uncontrolled after aggressive palliative treatment have been tried, for which treatment side effects are or are expected to be intolerable, but for which available treatments are unlikely to provide adequate relief in an acceptable time frame, considering the patient's prognosis, life expectancy, or level of distress. Then principle of double effect. It is used to ethically support palliative sedation, which is as follows. Good effects are intended, that is symptom control and comfort. The potential foreseeable bad effects are not intended, that is decreased oral intake, potential hypotension or respiratory depression. The good effects equal or outweighs the bad effects, that is rule of proportionality. Palliative sedation is morally neutral or good. There are no other treatments that would achieve the desired good effects without potentially foreseeable bad effects. Steps involved in palliative sedation, it includes to correct all the correctable causes with maximal therapy. Then aggressive palliative care intervention should be provided. Consensus among the treating physician regarding imminent death, communication with the family, informed consent, documentation of the intent, that is always relief of symptoms and not otherwise, and provision of care. Drugs include first line, that is haloperidol and midazolam. Second line includes levomipramine, and third line is phenobarbital and propofol. The dose of haloperidol, especially if delirium is present, we can start with 1.5 to 5 milligram subcut dose or IV dose with Q1 hourly PRN doses. Maintenance, we can use 2.5 to 10 milligram Q24 hourly with continuous subcut infusion or IV infusion. And midazolam can be used if the anxiety is prominent and there are no features of delirium. Start with 2.5 to 5 milligrams IV or subcut and can increase Q1 hourly with PRN doses. Maximum can be maintained up to 10 to 60 milligram with 24 hourly infusion. If a patient fails to settle with 10 milligram per 24 hour in combination with midazolam, consider second line, which includes levomipramine and phenobarbital. Now, respite sedation, it is a time-limited sedation to unconsciousness, or respite sedation may be used for terminally ill patients with severe refractory suffering in variety of situations. Incidental pain. Some patients may experience particularly severe pain or other symptoms due to therapeutic or diagnostic procedures or to necessary movement for other clinical care. Severe refractory social or existential suffering, one or more trials of respite sedation may break a cycle of anxiety or distress that has evoked a request for palliative sedation. Then European Association of Palliative Care provides 10-item framework for guidelines in palliative sedation. First is to recommend preemptive discussion of potential role of sedation in end-of-life care and an actively dying patient with contingency plan. Describe the indications in which sedation may or should be considered. Then describe the necessary evaluation and consultation process. Then specify consent requirements, indicate the need to discuss decision-making process with the patient's family, present direction for selection of sedation method, present direction for dose titration, patient monitoring and care, guidance for decisions regarding hydration, nutrition, and concomitant medications, the care and informational need of the patient's family, and care for the medical professionals. Next topic is end of life discussion with patients and the families. Communication at the end of life. The purpose of doctor-patient communication is to establish the therapeutic doctor-patient relationship. The firm establishment of this relationship is vital to a good therapeutic outcome, irrespective of whether the patient survives or not. Characteristics include patient and or family to understand the disease process in the question, the likely prognosis, the time that is available to the patient and family, and the comfort care options that are available. Goals of end-of-life discussion includes establishing consensus about disease process among caregivers, providing accurate and appropriate information about the disease process to their family, eliciting and resolving the concerns prompted to end-of-life discussions. Non-verbal communication may be as important as verbal communication during end-of-life. The acronym SOLAR stands for the method that the physician can use for non-verbal communication. S stands for standing squarely at eye level to face the patient and family for discussion. O is open body posture adoption. L is to lean towards the patient and family. E is to use eye contact and maintain a relaxed body posture. Physician style of communication includes inexperienced messenger, benevolent but tactless expertise, distance expertise, empathetic professional, the right, which is mix of empathy and medical competence. This physician is able to read both verbal and non-verbal cues and is able to address practical and potentially distressing concerns well with family perception. In patient and family-centered communication, an empathetic professional approach should be used, which do not influence or empowerment of the patient and family is maintained. It includes value statement by family members, acknowledging family members' emotions, listening to family members, understanding who the patient is as a person and how decisions are made in the family, and elicit questions for family members. Here is the spikes approach to the patient and family centered communication, which includes setting up and perception, invitation, knowledge, emotional support, strategies, and summaries, summarize the end of life discussions. Practical advice for family members regarding common issues that arise as patients are approaching death includes decreased socialization, that is, plan the activities and visiting when person seems most alert. Identify yourself by name or speak in a normal tone as hearing remains intact usually in end of life patients. Then decreased eating like foods or fluids as and when needed or wanted. Liquids preferred with the help of syringe without needle or a dropper. Small chips of ice or frozen juice can be kept in mouth. Taste or smell of familiar foods in small amounts is comforting to the patient. In disorientation and confusion, we can advise patient to the family to gently try to reorient the patient or the person if appropriate, provide reassurance. Sometimes limiting visitors can decrease the confusion, allow and acknowledge patient's experience, do not contradict or argue it away, record meaningful things that are shared, prefer to refer the photo albums or pictures to make it talk easier. Incontinence, in incontinence cases, we can use adult disposable briefs on the bed, apply lotions and cream, maintain dignity, provide privacy when changing pads or providing personal care. In congestion, turning the patient on their side to drain the secretion, to raise the head of the bed, then head end of the bed. Medications to dry the excessive secretions can be used, and mouth care. If the fever is present, continued fever, we can often use a cool washcloth to the forehead and removing the blankets. Consider using opening of window and a fan. In coolness of the body, we can use warm blanket, repositioning, and providing gentle massage. Guidelines and policies of end of life care. Nice guidelines for the adults, which was given in 2021, includes recognizing when a person may be in the last days of life, communication, shared decision making, maintaining hydration, using pharmacological management, and providing anticipatory prescribing. In ESMO guidelines, they say total care of adult cancer patients at the end of life includes assessment and diagnosis of impending death or dying, setting up goals of care, following multi-drug therapy holistic assessment, then rationalizing treatment, that is anti-cancer therapies, routes of drug administration, nutrition and hydration, medication and intervention review with anticoagulation, antibiotics, blood transfusion, and route of administration. Communicating and managing the symptoms related to fatigue, pain, nausea, vomiting, dyspnea, noisy breathing, and delirium, and intractable symptom management with palliative sedation, with social and psychological distress communication, and spiritual and existential distress communication, providing care, nursing care, nutrition and hydration, complementary therapies, and psychological support. We should also reassess and respond in case of death. After death, care of family and bereavement support should be provided. And these are IAPC 6 recommendations with advocacy for end-of-life care, with access to receive good palliative and end-of-life care is a human right, and all patients are entitled to a dignified death. It includes end-of-life care policy, and process of end-of-life care includes comprehensive care process to minimize end-of-life symptoms, managing psychosocial, emotional, spiritual, and existential distress of patient and families, and facilitating a dignified pain-free death. It includes an implementation of end-of-life care policy in all hospital-based care and community or home-based programs, with the end-of-life care standards and end-of-life care education to the doctors and the nurses, with under mandatory training in end-of-life care. Here are some guidelines for with 12-step approach given by IAPC and Critical Care Medicine Joint Society, which includes physician's objective and subjective assessment of dying process and medical futility, with consensus among all caregivers, with prognosticating uncertainty with expert opinion, then honest, accurate, and early disclosure of prognosis to the family, discussion and communication of all the modalities of end-of-life care with the family, shared decision-making and consensus through open and repeated discussion, with the resolution of pending conflicts, transparency and accountability through the accurate documentation, ensuring consistency among caregivers, and implementing the process of withholding and withdrawing life support, effective and compassionate palliative care to patient, and appropriate support to the family, after death care and bereavement care support, and reviewing the care process. This is 10/40 model, best care for the dying person. It is a model of care which aims to ensure that dying people can be provided with safe, high quality care by appropriately educating the staff working within the supportive organizational governance structure wherever they happen to die. The model was developed by international collaborative following a review of best available evidence in end-of-life care, and was underpinned in publication in 2013 by Elishaw and Lakhani. The 10 principles of best care of the dying person includes recognition that the person is in the last few days and hours of life should be made by the multidisciplinary team, and documentation by a senior doctor responsible for the person's care. Second is communication of the recognition of dying should be shared with the person where possible and deemed appropriate, and is with those important to them. Third is a dying person and those important to them, that is relative, carer, or advocate, should have the opportunity to discuss their wishes, feelings, beliefs, faith, and values. Anticipatory prescribing should be available for the symptoms that can be expected, example pain, and all clinical interventions are reviewed in the best interest of individual person. Then there should be a review of hydration needs, including commencement, continuation, or clinical assisted hydration. Also, there should be review for nutrition needs, including clinically assisted nutrition. There should be full discussion of the plan of care with a dying person, and where possible or deemed appropriate, and with those important to them. There should be a regular assessment of the dying person at least every 4 hourly, and review by the multidisciplinary team at least every 48 hourly. Care of the dying person for and those important to them immediately after death is dignified and respectful. Here is the Liverpool care pathway in UK for end-of-life care, which was developed by Professor John Elishaw in late 1990s in Royal Liverpool Care University. and Hospital with and Marie Curie Palliative Care Institute, and was published under guidance in 2003. It was adopted widely and welcomed at that time. In 2008 article in American Journal of Hospice and Palliative Care, the Liverpool pathway was criticized for its traditional approach and not taking an explicit position in artificial hydrations for critically ill patients. It included advanced care planning, order of attorney, advanced directives, and palliative care. Thank you.
Okay,
Prajakta, you're there. You can ask questions. You can put Prajakta, you're on mute. I think Dhanashri, you did a very excellent presentation. I do not see any questions on the chat, but we have another 10 minutes or so. So maybe we can, I myself think that it covered everything very much in detail, and whatever queries we might have had have been explained. But over to you, Prajakta.
Yeah, thank you so much, ma'am. If anybody has a questions, can either ask or can put it in the chat.
Rajita, can we take comments from Dr. Stanley, because he has done a lot of work in this area.
Sure, ma'am. Sure, ma'am.
Dr. Stanley, would you like to add
Sir,
something?
Yeah. Thank you, Dr. Sushma. Thank you, Dhanashri and Prajakta. It was excellent coverage of the very important and difficult area of care. Few comments I would like to make. One is, when a person is actively dying, he moves from being a patient to becoming a person, So that helps our attitude also, to consider him as a person. For example, like, a newborn, we say newborn baby, we don't say newborn patient. The same way, a dying patient, instead of that, a dying person helps our attitude, helps our relationship, which the families also appreciate. So that's one. The second I would like to suggest is, like, for the secretions, which is a very common problem. When secretion, the anti-secretory medications will only help further secretions. What has already been secreted needs to be, trickled out, by positioning or by gentle mopping. If you go on increasing your anti-secretory medication, it's not going to help what is already there. So it will prevent further secretions, but which is already there has to be removed by, positioning and by gentle mopping. Suctioning, again, unless you are a very experienced person, you should avoid that. And again, when you're in the last few hours and days, there is no place for active, aggressive management. In other words, thoracentesis or hypercalcemia treatment or ketoacidosis, all these things, you've passed that stage. Now your goal should be only for comfort providing. So whether it's in the hospital or at home, you're not going into any aggressive treatment. So that is the important thing. Otherwise, we still remain confused, And about palliative sedation, always it is very difficult to rule out delirium, and delirium is very common. 88–90% of people have delirium. So whenever you use, say, midazolam, you always combine haloperidol. Otherwise, you may have a patient who's what we call a locked-in syndrome. Because of midazolam, he's not able to respond, but he's aware. So that's a very, very terrible situation to be in. And so always combine haloperidol in the palliative sedation is what I would say. And then, the two things, that is the Indian, guidelines, the end of life care policy or integrated care plan by the joint societies, IAPC and ISCCM, have been combined with the 10 principles and the 1040 model of the collaborative. And this is what Dr. Naveen has done in the Blue Maple document. So that is a good area where we can combine these two things. And the one thing about the Liverpool care pathway has been totally discontinued. And it is the same, Dr. Ella Shaw, who then went into creating this collaborative because of the lessons learned from applying the Liverpool care pathway. So those are a few comments I wanted to make. Thank you.
Thank you so much, sir, for your valuable inputs. And as you said, we really think that the patient, we should not address them as a patient. They are as a person. We should call them by their name.
Yeah.
And as you said, the secretions about the palliative sedation, haloperidol and midazolam, we always practice that. And whatever you have said, we'll keep them in mind also. Thank you so much, sir.
There's one more question about diabetes management at end of life. Would anyone want to take that? Status of drugs to control diabetes at end of life. I think it's partly been said by the Stanley sir that we are not really looking at managing anything aggressively. We are just looking at comfort. You want to add anything, Dhanashri or Prajakta or anyone else?
Yes, ma'am. Especially when there's a guideline for like deep prescribing in palliative care. So usually those medications like oral hypoglycemic agents or antiplatelets, multivitamins. So we usually should avoid such medications when patient is like actively dying.
Thank you.
So Joyita, are there any other questions? I don't think all are compliments, I think.
There's this one last question about, ma'am, sorry. What to do about oxygen in EOLC? And the second one is second line antipsychotics that you have used. Meenakshi wanted to ask.
And there is one more question. Any data on use of Saath Saath helpline of IAPC? We'll take one by one.
Yeah, so the first is about oxygen in end of life care. So oxygen is only been started only if there is hypoxia. Otherwise, it is not indicated. I hope this answered your query part. And the other one is second line antipsychotic that you have used. So we have used only first line. Levothyroxine is not available in Tata, so we have not used that.
I just want to add, Meenakshi, that if it is delirium, if it is terminal delirium, we have usually managed with, most of the times we've been able to manage with haloperidol. Very rarely, if we had to use any other, we have used quetiapine. And the third question about Saath Saath helpline, maybe Prajakta and Dhanashri will not be able to answer that, but since I am part of that, I don't think our calls are meant for, the helpline is meant for that. It is mainly for palliative care needs and then referral to appropriate agencies. So on the, I might have to check, but I don't think that we've got any calls for the actively dying, or we wouldn't have been able to make out if it's actively dying. Maybe the detailed call logs would have that, but that's a good question. I must check up and will pass on the information when I get it on the group.
Thank you so much, ma'am.
So I don't think there are any other question. Anybody wants to have any comments? Joyita, would you like to summarize this session?
So I think it is a very important topic. It is very important. It is a clear, it is in our mandate and it is our duty. It is not just quality of life, it is quality of death that we focus on. And this is something that others are not able to do and we are able to do. And hence we must be knowledgeable, have the proper competence, attitude, and skills. And Dr. Dhanashri gave us a good presentation on how to manage the symptoms and how to understand the science behind it. Thank you, Dr. Stanley McAdam, sir, for, those are the really great points that you said about patient to person. And we covered and the other points that you said. And just to the few questions that asked, I think because the presentation covered most of the points, and this is something that we have to use in our everyday practice. So thank you, Dhanashri and Prajakta, for making us aware and learn more. And thank you, Sushma ma'am, for giving us the opportunity to present on this important topic. Thank you very much.
Thank you, Joyita, and thank you all the audience for joining, because after attending such an exhaustive conference, you are here. This has inspired speaker as well as moderator. Thank you, everyone. We will see you next week, Monday before 6:30. Thank you, Prajita, Dhanashri, Dr. Joyita, Dr. Stanley, Nisha and Archana. After so much of work since last almost a week, you are here again at 6:30. So you are great, and everyone those who has joined. Thank you very much. Thank you, Prajita. Thank you, Dhanashri.
Thank you, ma'am.
Okay, Joyita, thanks a lot. Thank you.
Thanks,
Bye
ma'am.
bye.
Have a good day. Have a good week.
Bye. Good day. Have a nice
Bye.
week.